I'm Chris Davis. I'm the Butler County 911 Director. I've worked for Butler County over 30 years. Started out in EMS, spent 10 years with Butler County EMS. Moved in 1998 to Butler County 911. I've been the director there since 1998.
Yeah, and really help develop the baseline of what we have in the 911 center now.
Yeah, we, in 911, we implemented our EMD process, I believe in 98, it might have been 99. All of our staff are certified through the International Academies of Emergency Dispatch. We've used that program, like I said, since 1998. Well, we became accredited through the Academy in 2016, and we've retained that, we've re-accredited up to the present.
Excellent.
I'm Dr. Paige Dodson. I'm board certified in family medicine and preventive medicine. I currently work full-time emergency medicine. I'm medical director for emergency medical services and the communication center, which means that I sign off on the protocol. So I help to determine the best clinical course of treatment for our patients and make sure that we have safe care delivered every time.
And you're also involved on the regional and national level with search and rescue, and been able to refine your skills and provide your services to the region and the state as well. So.
Yes, and I've been involved in the State Board of EMS on the Medical Advisory Committee, so that looks at standards of EMS statewide.
Yeah. We're very fortunate to have both of these experts in their fields, from the clinical to the 911 Communications Center. And with that, I'm Frank Williams. I'm the Director of Emergency Medical Services here in Butler County. I started my career here in Butler County and just recently came back home to Butler County to be part of this great team that we have here. We have 5 advanced life support or paramedic level ambulances that serve Butler County, and then we have 2 backup units that are available as well. We have a staff of over 40 personnel who serve the patients here in Butler County, and very proud to be a part of this new program that we're getting ready to start. While I was here at Butler County serving as a lieutenant, I was able to go back and increase my education, got my bachelor's degree in nursing, and so went down the pathway of critical care nursing. So I got to do that in a hospital system for a few years, and then was fortunate enough to go into my dream job of being a flight nurse in the flight world. So that's been the last 24 years of my career, is providing care in the air and or helping lead teams for care in the air. And we've known for decades that the baby boomer generation, as they start to enter the healthcare system more and more often, that our volume was going to go up. I mean, a lot of these things were predicted. What we didn't predict is that resources in any individual community couldn't keep up with the demand. Every day, it seems like our call volume is increasing, but the number of transports, once we get on the scene and do an assessment, find out people are non-emergent, it's not, something that needs an ambulance transport right now, is decreasing or increasing, and the decrease of needing transport is pretty obvious in all the data we've looked at, which falls in line with all the national information that we're getting back.
We're lucky to live in one of the counties that does have population growth in Kansas, so
Yep.
we know that we have to plan for the future more calls.
Yep.
And that's just the reality, is that it's going to happen. So we want to mitigate that cost and try to prolong that sort of inevitable outlay of funds as long as we can. And the best way to do that is to try to be as efficient with the resources that we have as possible.
Once an ambulance does begin transport, there's only certain places that we're really allowed to take those patients. So we can't take them to a doctor's office in an ambulance. We can't take them to an urgent care like normally you would go in your own vehicle to. We're held to standards, regulations, reimbursement standards that we can only go to the hospital that's closest and most appropriate for that particular injury or illness based on the patient's preference. But it's not like we can bridge that gap to the urgent care, the minor emergency center. Those things, once we start transport, are regulated to not be able to do that.
potential solutions that we looked at was a program called ECNS through the International Academies of Emergency Dispatch. And essentially what happens is in that program, nurses are hired to be in the 911 center. And when we come up with low acuity calls, and we'll talk about that in a minute, they're transferred to that nurse, and that nurse does that safety screening and then comes up with alternative care for them as opposed to sending an ambulance. What we discovered in looking at that model was that for a community our size, it was just a little too expensive.
One of the benefits of telemedicine is that we can access these resources without having to hire people to physically sit into triage and to pay that nurse's salary. Honestly, it's usually more than one nurse once you have to cover all the hours.
Right.
And so telemedicine allows us to access those resources, combining our resources with other communities of similar size that also need to access those resources, and then it makes it more affordable for everybody. Telemedicine is a really exciting idea. It's showing more and more promise, lots of outcomes data to show that it's safe and effective, and we can more and more readily assess someone without that physical connection in person, but still have the same outcomes.
There are other programs out there we're still researching as far as the ability to integrate telemedicine truly with face-to-face contact at the bedside. Other things that we are looking towards as we're trying to solve these challenges with not having enough ambulances to meet the demand. The only other option that we've identified is to use tax dollars and expend those tax dollars to add more ambulances, more trained personnel, more equipment to meet that demand.
When we looked at the other programs that we visited across the country, one of the things that's real clear is that as they've implemented these programs, they haven't had bad things happen. They've followed these over time. They've had lots of experience now, several years in many cases, and they've been able to appropriately take care of the patients, get them to the right source of care without making mistakes or having people fall through the cracks. And so when we look at this, we're really thinking it's a value-added service. We're trying to help people find the most appropriate, most cost-effective entry into the healthcare system without utilizing government resources and ambulance that in our case is taxpayer funded. And so there's a reason why we have a incentive to do this in the most cost-effective way possible.
Absolutely. And then it frees up those ambulances from those non-emergent, non-life-threatening situations to be available for when that real life-saving event needs to happen. And that next 911 caller is somebody who needs those services of the ambulance.
And to that point, as we looked at the data, we found that these lower priority calls that really very often don't need an ambulance response at all, they make up about 25% of the total call volume. When we studied that against what we call system status management, that when we get critically low on ambulances, we found that those low priority calls make up almost 55% of the demand at the time that we're running out of ambulances.
So we looked at, could we do this ourselves without a vendor or a partner? And the reality is we didn't really think we had the infrastructure to do that. We thought it would take us too long, cost too much money, take too much time to sort of develop this. Plus it would probably have extra expense in staff and so forth.
And what is the cost, specifically the taxpayers, on this program? So I think that we've identified, and Chris mentioned the pilot program of this, it's going to be very economical for us. And the money that we will be spending will be for some training to enhance what's already established in the 911 center.
Right. As we begin to roll this out, we're going to try to do it spending virtually no money. We may learn that there does need to be some money spent there, but we don't anticipate it will be much at all.
Right. And we've also weighed, the cost of doing a program like this to reduce the actual 911 responses compared to adding resources such as another ambulance, equipment that goes on that, the trained personnel, increasing our staff as far as EMS. Definitely there's a much more economic path with this program than it would be to add those. Not saying that in the future that won't have to happen, but definitely this helps smooth that transition of when we do have to put in those additional ambulances and crews on the street to answer the call.
When it comes to federal dollars, we're actually sort of in the middle. So we're not a huge urban center, but with all the growth, the Andover side of our county, where there's a lot of people, then that rules us out of the Frontier grant dollars. And so we're sort of in this middle place where, like I said, we don't really have the resources to do it ourselves, but we're not big enough to apply for these big, massive initiatives that are going on at the federal level, and we're not small enough to apply for grant dollars. And so for us, we were left looking at vendors.
We haven't identified a date yet. We're still working with our commissioners and making sure that we have everything in line before we step into the program. So an actual go-live date hasn't been selected yet. We hope in the early part of 2020 is kind of that goal.
The 911 operator will stay on the line with that call, and as that healthcare professional evaluates that person, we're listening. And if that professional says, we should go ahead and send an ambulance for this, there's no need for another call or anything like that. We'll send an ambulance at that point.
The other thing to remember is that this isn't every single call that's going to necessarily be referred to our new program. Using the data that we've collected over the past number of years, call types, when someone calls in, they're identified, it's assigned to a specific potential diagnosis, really is how they work. But so only the calls that we've identified that fall into certain categories that we know are most likely to be non-emergent will be involved in the program. So if someone calls in and says, I've had a motor vehicle accident, that program, that patient is not going to be referred to the program because it doesn't apply. We know that those patients are going to need an on-site assessment by one of our medics, and that the phone isn't going to work there. But if someone's calling in for something like belly pain, and it makes sense that you can tell by talking to them that they don't sound sick, that's one that we might consider depending on what case and how their symptoms are. We're only looking for the things that we think are most likely to not need an ER visit.
Yeah, great point. So any of those emergencies we know up front, motor vehicle crashes, falls from a height, I mean, any of those situations that we know are out in the public, we can't get good information on, those won't even be considered for the program we're talking about. They'll be eliminated from the very beginning, and an ambulance will immediately be dispatched to that situation. So, good clarification.
Going to monitor every one of these calls, and we have the flexibility in the contract to adjust everything in that process. The procedures are ours, and we'll have constant good communications and free flow of data. I'm sure that some folks have a concern that if I call 911, are you going to create a delay here before I get an ambulance? Can I have an ambulance? Those kinds of things. Our procedures very clearly are set up that if someone wants to have an ambulance, they're going to get an ambulance. We're not going to force this approach on anybody. If they prefer not to talk to a physician or a physician's assistant or nurse practitioner, and they want an ambulance, we will send an ambulance, and it will not create a delay.
We have definitely the patient as the center point of what we're doing, no matter who calls. If they need an ambulance, we're going to send an ambulance. There's other alternative resources have been reviewed, and the information has made us feel comfortable, and Dr. Dodson, who's walked this whole path to feel safe that that particular 911 caller is non-emergent, and we have other groups of physicians and mid-level practitioners that can intervene, not just nurses, And I'm a nurse, so, but we have that higher level of care that's immediately available, and we're not hiring them as employees of Butler County, but it's through this contractual relationships that are available to be able to bring them into this as a resource. In Butler County, our 911 center is more advanced than a majority, even across the Midwest. And the ability to already take a 911 caller's information and be able to quickly, through questioning, find out, what the real core issue is, whether it's an EMS call, law enforcement call, fire department call, whether it's emergent, non-emergent, and all of those things ran through an accreditation, which Chris's department has done a great job of establishing and maintaining for several years now. So I think those templates help a bunch for Butler County to be able to take this next step.
Yeah, the core functionality of this is not new. It is something that we have done for many years. Since about 2012, we've really gotten good at this in trying to become accredited, and that is the foundation of this entire system, to be able to safely prioritize these folks, recognize what is an emergency, what's not an emergency, and safely choose those folks that could better be served by being referred to a doctor.
Emergency care is absolutely essential. We must have ambulances to take care of the truly life-threatening situations. But a lot of times, interacting with your own care provider and your own doctor is actually safer, because they already know your allergies, they already know your medical history, they know your medication lists, and when you're sick or in distress, you're not always the best person at giving that information out either. And so the paramedics have to walk into these situations not knowing that information, and so there's a potential risk there.
Absolutely.
And that's why continuity of care is so important. In some ways, redirecting these non-emergency patients back to their regular physicians actually makes it safer, better care.
And ultimately, they would have gotten better service, more appropriate service, had they chosen a different path. Not just would we have saved an ambulance trip, but they actually entered the healthcare system at a most appropriate point, and they would have ended up with better follow-up care. And so that's one of the beauties of MD Ally, is that's exactly what they do. They interview the patient, a telemedicine approach type thing. Sometimes they'll give home care instructions, but at other times they have, if that patient needs to see their primary care physician, they can facilitate scheduling an appointment. They have tools that allow them to see doctors' scheduling, so they're integrated with area physicians so that they can see who has an opening or what time they could get that patient in. If that patient doesn't have a primary care physician, they can look at other physicians that would be available to take that physician, schedule that appointment. They've also got some transportation experience helping those folks that maybe they called 911, they want to go to the doctor, but they don't have a ride, they don't drive, whatever the situation is. They've got tools to help facilitate transportation as well. So I think it's a beautiful match with MD Ally. That is their business model, and I think it's going to be well received, and I think it's going to add value.
So our partnership with this vendor is really based on the fact that they have done that legwork that seems to line up very well with other programs that we've talked to. Many of the things they say and they talk about are very much in line with what we had researched and decided that we agreed on to be best practices ourselves. But they have a little bit more experience, and they have developed that infrastructure and starting investing so that we're able to piggyback on what they do and not just have to start from scratch.
So we were talking about MD Ally, and that being a vendor that really stuck out to us, a partner that we really think is going to do what we needed to do for Butler County. Any other thoughts about MD Ally?
Well, I do think that it's encouraging that they're interested in looking at a community of our size. That was one of the big challenges, I think, that we were concerned about, was that those approaches had really only been taken in large urban environments, and we weren't sure, well, we were tickled to actually have a partner that was interested in, somebody with our call volume.
Yeah, so that opportunity definitely was obvious as we look at CMS and Medicare and what they're doing, because they're trying to do some of these same things through pilot projects that have just started in the EMS world, but unfortunately, we just don't have enough volume to even qualify to apply for those. We hope that will come around to the rural and frontier communities that we live and love, but right now it's focused on more urban areas. So I agree, it's a real blessing to find a partner that would focus on such a smaller volume of help.
And the relationship with MDLA has matured over a period of time. We've been working with them for a period of time. This is not a one-size-fits-all approach. It's very much a partnership where they're looking at our community and our needs and developing a program that's actually going to work. They're not just implementing this directly as they've done somewhere else.
Right. Yeah, so we've definitely vetted them out, done the research, talked to other providers in other states that have been associated with them, utilized some of their services, and we have the opportunity with the agreement that we'll make with them to stop that program at any point. If there's any risk that we identify at any point, we have the ability to stop right there and then.
MDLA has been very good at being creative and not insisting on very expensive computer integration with our computer-aided dispatch system. They're willing to use some alternative means, such as communicating via email. We will be able to pass information in a live way, but without necessarily having to spend a lot of money up front. They're willing to give that a try. We're excited about that. We think it will work well.
Because that's a question that a lot of people have is this some sort of fantasy land? How is this going to work?
Right.
Somebody has to be making money somewhere.
Right.
The benefit of this program is that because at the other end of that telemedicine phone call, you have a provider that can bill. So the physician assistant, nurse practitioner, through the new telemedicine regulation and laws, is allowed to bill for that service. And so they could bill your insurance as appropriate based on that call. And those things typically don't have an additional cost to the patient. It's the insurer that is willing to pay for telemedicine because the insurance companies also see that when the patient gets the right care in the right setting, it's overall more economical for the insurance companies as well. So because of the benefit to them, they're willing to invest in telemedicine. That's a big difference in our program versus programs that use nurses in that nurses can't bill. And so that's a big part of how the pilot makes sense.
And just based on the restrictions that we have as EMS, we can't charge for our services to an insurance company unless we actually transport the patient. So these non-emergent 911 callers that we respond to and we arrive on scene and we do an assessment and talk with them, and the decision's made that they would rather not go by EMS and be transported, or we find a family member, because they're non-emergent, could safely transport them in their personal vehicle to an urgent care and emergent care, we have no basis for reimbursement there. Insurance companies, won't allow us to charge for those services, especially Medicare, who set those regulations. So at that point, we have utilized our services to respond, our crews to do the assessment, identify that the patient's, non-emergent, has other options available, but we've done all that without the ability to get reimbursed for it.
And the reality is many of the private payers are not paying for ambulance transport if it turns out that it was non-emergent.
Yeah.
And so there's a potential cost savings to the patient too, because even if they are billed for the telemedicine visit, it's considerably less than being billed for an ambulance service,
Right.
that their insurance company is gonna come back and say that that transport wasn't needed.
Yeah, so if we did decide to transport the patient, they're non-emergent, and like Dr. Dodson pointed to, that there is, the insurance company decides that really didn't equate to an ambulance being utilized for that, then yeah, that insurance company won't pay, and then the patient is held responsible for that, unfortunately.